Today is Q&A session with Dr. Sandorfi. I just wanted to take a second again to thank Dr. Merkel, Dr. Ligon, Dr. Dirk, Dr. Reynolds, who was here earlier, as well as a couple of our volunteers who have been here, Desiree and who am I forgetting, as well as a couple of board members who are here. Would you raise your hands, board member? Thank you, Diane, as well as Joyce. And if you have any interest in joining our board, the national board is also looking for people to recruit, as well as the National Patient Conference, which is in July in Arizona, of all the warm places Dr. Dirk mentioned. The scholarships are now open for anybody who wants to apply. March 16th is the deadline. So reach out to us or Colleen for any information about the scholarship program that they have. And again, on the back of your program today, there's events. If you live in any of the areas close to anything that's going on, we've got soup cook-offs, cruise, car shows, all kinds of things going on around the chapter. So please get involved and help us support these events. And this part of the program, we're actually going to pass microphones around to you for questions. And I believe, Dr. Sandorfi, we're going to actually wire you up with this thing. So you're already wired up. Very good. Well, without further ado, I give you Dr. Nora Sandorfi.
And I keep forgetting this. I have to have something to hang this on. I never have it. It's okay.
Yeah.
But that's not the problem. The problem is this. I also wanted to thank Jackie and Marina. They are. They are, Matt, they are our research coordinators, extremely important part of the team. I just actually talked to them because I'm getting all these emails related to clinical research. You guys know that we have had a couple of sessions before that we talked about the clinical research that's happening at Penn. If we didn't have them, we wouldn't be able to do it. I mean, the regulatory forms and all those important things that we have to follow up with and have to be compliant with, believe it, it's not we who are doing it. They are the ones who are making sure. So I would be like Monday morning seeing the email from Friday that the email was supposed to be answered in a couple of hours, and I get a heart attack and texting Jackie, who's probably cooking soup at home, like, what? I'm like, did you do it? Did you do it? She says, of course, it's taken care of. Don't worry about it. I'm like, holy cow, you know? So very thankful for, they actually helped us to organize this. And I think both of them have been going for your meetings and walks and stuff like that. So it's important, they are an important part of the Scleroderma community. And thank you so much again coming out that cold day and having us here. And I'm lucky enough, just didn't have to prepare a talk, but I'm doing the Q&A session today. So hit me. Let me see if I can answer those questions. Yes.
There's a lot of work being done. You guys, could you wait 1 second for the microphone to come to you? Thank you.
So I know there's a lot of work being done on the endocannabinoids and CBD2s. Are you guys doing anything new with that?
Well, I heard it. So cannabinoids. Guess what? We just got the study, and we just sent back the paperwork for the study, so the site got approved. So we are actually going to be part of the cannabinoid study. We have to get the paperwork ready and has to go to the IRB, which is the regulatory form. And then after that, we open for patients. So we are going to be involved.
Do you do any work on the CBD2s at all that you can sort of do without having to have it through a prescription?
I'm not sure I understand your question. Do I have any work on?
Do you guys have any experience with any of your patients trying the CBD2 kind of products that you can get?
So it's almost like hearsay. So I try not to. So, you know, cannabinoids are, it's part of marijuana, right? So it lacks so it depends on what receptor. We gotta go into all this receptor business here, okay? So we have all these receptors where the different part of the weed can bind into, and there are some in the brain, some in the immune system, some here, some there. So the cannabinoids, so in general, we use that particular, just the part that's not gonna work on the doesn't have hallucination, but the central nervous system effect, but only works on some other parts of the drug and in the body. So what they do is they separate that part, and they're using that for, like in scleroderma, we're going to use it for skin, well-being, joint pain, and things like that. So it doesn't, so it lacks the brain effect and that, good feeling or whatever, we can go, high effect of it, but hopefully will have a benefit on the scleroderma-related symptoms. So do I have any experiences? So I have to tell you that I have a couple of patients who tell me that somehow they have sources they get them from.
Is it video? Are you being videotaped?
So I just I just close my eyes, ears, nose, everything. So some people do say that it works for them. So I mean, what am I don't know what to say. So I really don't have experiences with it, but patients come in and they tell me that that somebody is working in this company or that or whatever. Somehow they get these products. So we actually the question for me usually is, can you prescribe medical marijuana? And I cannot prescribe. We cannot prescribe. You have to have. It has to be a doctor who has the license to do that. Whether we can get the license, it's questionable. Whether do I want to have the license, it's also questionable. Not because I don't want to be involved in it. It's more like I think whatever is out there is like, we have the cookie form, or this form, or that form, different kind of badges, this good, that good. I mean, I have no idea what I'm doing. So I usually tend not to do things when I have very little understanding. I'm not saying not to do it, but I would not personally like to be involved in a sense that I cannot tell you, take 1/4 of this cookie because it's a better product or less good product and whatever the effects are. So I'm very excited about the cannabinoid study because that's going to be controlled in a sense that we know what we're giving. You know the milligrams, the efficacy, how it's going to work. Hopefully it works. The preliminary data, I was on, we have this yearly conference for rheumatology, and I was on their briefing for preliminary data, the first batch of patients who have used it or taken it, and it seems very encouraging. So I'm extremely happy to be involved in it and provide our patients with the opportunity. Again, we'll see who qualifies for it. That's always the problem, who qualifies for the study. We have all these studies, hard time enrolling because the patient population has to be very clean, if you wish. You can't just have everybody coming into studies because then you don't have the right results or the valuable results for the particular therapies. I hope that answers your question. Yes? You're going to be scolded. 1 second.
I haven't heard anything about telangiectasia being mentioned. Is that a serious effect of the scleroderma?
So I guess telangiectasia wasn't mentioned because that wasn't the skin that we talked about today. Telangiectasia can be just an unfortunate, just an aesthetic problem. The little red dots on the face and anywhere else, arms, chest, fingers, hands, The problem with telangiectasia occurs when it's inside the stomach. So that's the so-called watermelon stomach, when those can actually bleed. So often anemia that we see, which is like a low blood cell count that we see in patients, the source of that is from slow bleeding from those little dots inside the stomach. They can open up, they are very fragile, and there is a slow leak, and people become anemic. So, and then what happens, we send the patients to the gastroenterologist. When you look at other autoimmune diseases and anemia, many times we send patients to the hematologist. In scleroderma, your first choice shouldn't be the hematologist. It should actually be the gastroenterologist because that's the most common reason for blood loss, bleeding, little tiny bleeds from the stomach. Okay. Have to honor. She was just a touch before.
Thank you. In terms of the overlap syndromes, one of the antibodies that wasn't up there was the PMSCL, and I was just wondering if that in itself is an overlap syndrome because it contains both autoimmune diseases, or is that
I think I can answer, but I give it to the right person.
Yeah, I appreciate the shot. That's probably, I think, better thought of as a subset of scleroderma. There's a specific antigen, the PMSEL antigen, that was identified within a scleroderma context. So that's some of what I was alluding to, and I kind of intentionally avoided that because of the difficulty of this issue. And I think in that case, as a good example of a situation where you treat the effects, you treat the muscle weakness, any muscle inflammation, you work up those kinds of downstream problems as they come up. It does give us information, kind of what to expect with the scleroderma course over time. It tells us that the muscles are likely something we need to be paying more attention to over time. Interstitial lung disease also may be associated to an extent, but that's probably where that ends. Yeah.
As an overlap syndrome. As an overlap syndrome, what's the difference between rheumatoid arthritis and inflammatory arthritis?
Right. We're testing him, first year at the.
No, good question. Some of these, so in scleroderma, inflammatory arthritis is a more general term that probably includes rheumatoid arthritis as a subset. There are other forms of immune-mediated joint injury that causes inflammatory arthritis, in the sense that if you took fluid out of a joint, you'd see a lot of immune cells in there that we wouldn't think of necessarily in the same way as rheumatoid arthritis. And if you took a biopsy, it would probably look different on a slide of the lining of the joint. Effectively, what we look for clinically, practically, it ends up being oftentimes the drugs that we're applying for. Insurance companies won't give us biologic medications oftentimes for inflammatory arthritis, so we'll call it rheumatoid arthritis. But what is important to remember sometimes is that scleroderma can have a particular type of high, kind of, we think, IL-6 mediated inflammatory arthritis that might respond in particular in some studies to tocilizumab is one that's been shown particularly helpful for this. And that often involves kind of tendon involvement as well in scleroderma. And those are features, certainly the tendon involvement is not something you see in rheumatoid arthritis. So it's probably slightly pathophysiologically different. In practicality, probably not a big difference.
Are you sorry you asked? So your best bet is to enroll into rheumatology fellowship program, okay? It gets so darn complicated, but even me, like, what is he talking about, It gets really, really, so to be honest with you, I think sometimes on the patient level, it doesn't make a big difference as long as we understand what the heck we're talking about. Outcome-wise, treatment-wise, doesn't make much of a difference. So we just do, a lot of splitting this, splitting that, and categorizing and not categorizing. A lot of like surveillance. Actually, to be honest with you, I think what's really fun about rheumatology is that we still don't have those like algorithms and boxes, and you still have to be a physician. A lot of it is, as Dr. Lagan was pointing it out, is like you gotta look at the patient, examine the patient, and listen to the patient, and so forth, and then you get all the other studies, right? So I think it's kind of still neat that we have to have that hands-on. And many times when we train fellows, I always tell them, it's really no difference whether you are in apprenticeship for like, building a house, or you doing it for rheumatology, because a lot of it is just hand-on. It's a trade. It really is a trade. So, well, pass it on. Okay, good.
What do you think about CellCept for systemic scleroderma, and how important is it for patients to be on that?
So I think of it often. Actually, Dr. Dirk is instrumental in introducing, we call it mycophenolate is the other name, CellCept, we have this trigger reaction. Our boss chops our head off if we use the medication's name, like you use it. So we all go like this. So we start using the, is he here somewhere, But the generic name of the medication is mycophenolate. Some of you know it that way. Some of you know it as CellCept. So all of these medications have to be given in right circumstances. So it's not, there's no generic drug, right? There's no, oh, you got scleroderma, salsa. There's no trigger reaction like that. You know, you always have to carefully select the patient. Typically, we use it for very progressive skin disease. We use it for kind of like an overlapish kind of symptoms, meaning skin and then some other inflammatory components, sometimes lungs, sometimes, you know, we had some scleroderma renal crisis patients we used it in, but not, there's no one general medication. It is not a general medication for scleroderma. It's a good drug. Being said, nothing has been approved as a, okay, I'm going to throw out another terminology, disease-modifying medication for scleroderma, but I think we often think of it as maybe Cellcept is one of them that we can use with success, but again, in well-selected cases. Okay? Yes?
My question is, this is a very complex disease, and obviously they're not sure what triggers it, environmental or other reasons. And the question is, how many times have you found where a husband and wife have scleroderma? Because they're very, very different gene pools. And then have there been any studies done on just husband and wives who have scleroderma that might lead to showing what caused this?
Okay, so I think you answered your own question. It's how often, like, do you have anybody, husband and wife? You? No, I don't have anybody either. So I think it's super rare, super rare, and you know, I think you kind of suggesting that there may be something that's similar environmental exposure, but it's not enough because the same environmental exposure affects all of us, right? It's the genetic setup. So I'm very fascinated. I have not scleroderma, but a husband and wife, lupus, and they actually, when first I started seeing the wife, and then eventually the husband hasn't been diagnosed, but I actually diagnosed him with lupus as well. And then when we started talking, they told me that they were very, very poor, probably all of us at the beginning, and they could only afford to live on that. They were living in California. They could only afford living in this house that was on it or built on an old gas station. And because they were so poor, they were actually growing plants like tomatoes or whatever, vegetables. So whether that's the reason, I don't know, but how often do you see? We don't see husbands and wives same disease, unless it's just like an odd, you know, combination or just happened by accident. Oh, you don't. You got fried. No problem with Raynaud's, it's all hot. Next. Who has it? Oh, yeah, okay.
I have 2 questions. Is that all right?
But yeah, go ahead.
I actually had one for Dr. Reynolds, but maybe you can answer.
Dr. Reynolds.
Or
He's not here, but I figured you want to be Reynolds.
or if any
Yes,
of
go ahead.
you maybe can answer.
We'll see.
I was just wondering, are there any new treatments for dysmotility?
Oh, Dr. Reynolds, who was here. Oh, I'm not talking about Reynolds.
Yeah.
Okay. Any treatment for dysmotility?
Any new ones?
No. I'm looking at the other, they're shaking head too. Unfortunately, no. And the one that we had in the past, domperidone, actually has not been on the market anymore because of side effects. I think it's still available in Canada, in some parts of Canada, but I have a couple of people who got it from Canadian pharmacies. So we're not using it anymore. Okay. And no new drugs on the market, unfortunately.
Okay. And my second question was, has any research been done actually about immunoglobulin, like IgG4 disease and Scleroderma? Because there's IgG4 disease, also diseases causes sclerosis in certain parts of the body, and I'm wondering if any of that is related or correlated, or is it completely separated? It's fairly new, so.
Yeah. So IgG4 disease is, you guys think of it too. IgG4 disease is kind of a newer diagnosis. I think we always had those kind of patients, but we are recognizing, interesting thing is that we actually define new diseases as we go along, and when we see more and more of those patients with a certain combination of symptoms, we define new diseases. So IgG4 disease is a kind of condition where people can get hepatitis, pancreatitis, fibrosing conditions inside the body, and then thyroid disease. They can have some joint involvement. So what's really interesting about the condition is that when you do the biopsy, on the biopsy, the cells, these immune cells, stain differently. We find more of these IgG4 cells than the other IgG cells. So we're getting very, very sophisticated here. But the point is that I am not aware of Scleroderma being associated with IgG4, the presence of IgG4. We have other conditions, other autoimmune diseases, Sjogren's disease. There are some forms of Sjogren's, the so-called, we used to call it Mikulit's disease, that was IgG4, that is, we believe is IgG4 associated, and those people would get not only, in Sjogren's disease, you see the parotid glands and, I'm going to show it. Put it on my ear. Doesn't work. So in Mikulit's disease, there's symmetrical swelling of the parotid glands and also the tear duct. So patients would come in with really, really swollen eyes and very, very swollen parotid glands. And they would tend to get lymphomas and so forth. They had a very aggressive disease. And now looking back, it appears that when they take a biopsy of their glands, the ratio between other IgG 1, 2, 3 and IgG4 is different, is more for the IgG4. So really, this is a whole different topic of conversation, but I think the bottom line is that as far as I know, there's no Scleroderma and IgG4 association. You guys? No. We all concluded one of those cases. Yes. Jackie?
Do you know what is going on with the plasma research?
Oh, the plasma research. I have, I think, 1 or 2 patients. Anybody knows the plasma? What are you referring to? I thought it was.
I know very little about it at this point. It all started when I saw an ad in the newspaper for scleroderma patients to donate plasma for research into plasma being used to help cure autoimmune diseases.
I thought it was for lupus. I have a couple of people involved in the plasma donation for lupus.
The ad said lupus, scleroderma, and other autoimmune diseases.
No.
Basically, they collect your plasma and I'm in that study, and they collect your plasma. They give you a certain amount of money for donating, and they basically, I think what they're doing is then selling it, or I don't think they're giving it. I think they're selling it to laboratories or people for other people to be tested. Like apparently, if you have this antibody, and so they can compare
We
them.
don't know what they're doing.
I don't know what they call it, but so that they compare them to say, yes, you have that antibody because you matched with the other thing. And then for places where they're just going to use the plasma and then do some kind of experiment on it. So they need certain people with certain types of antibodies. And then so basically you just go to this place, which is way up near Hunterdon, and you just give your plasma. Takes about 3 hours or so, and you do feel a little bit better for a small amount of time because you're actually getting rid of some of your autoantibodies that are, so you kind of feel better for like 2 or 3 weeks. And I said, well, why don't they use this as a treatment? And they said, because you can't just take your you can't just take your antibodies out all the time. You won't have antibodies against other things too. So I don't know that it's like that you're doing a great deal for mankind or anything, but I guess the scientists do need the plasma to work with, and then people need to get tested, so they need to have it.
I would not like to promote that as a therapy, if that's
Yeah.
possible. Okay, so
Yeah,
please-
no, they told me it's not a good therapy.
Yeah, so
no.
yeah, we're not doing that for not a well-established feel-good method. Okay.
This is a question for all of you and everybody in the room, really. My gastrointestinal tract is severely affected by my scleroderma. I've over the last 4 years done a lot of diet modifications. Dr. Sandorfi is my doctor, and I'm just wondering if all of you have noticed with your patients that you're seeing that more and more. I've eliminated gluten, which is a big one for me, along with a lot of other things. And I get a lot of relief from doing that. I'm just wondering if anybody in the room or the doctors can speak to that.
I speak to that on my end, and will be the same that I always tell you. So there are some anti-inflammatory diets that have been recommended by the Arthritis Foundation. I know that some of my Sjogren's patients utilize those. That's been not overly studied, but somewhat studied and recognized that there are some benefits of the anti-inflammatory diet. I don't want to go into it, what they are. You find it on the Arthritis Foundation or the Sjogren's Foundation website. I usually don't prohibit diets unless they are so-called boost the immune system kind of diets. You don't want to boost the immune system by any means. If anything, we're trying to like temper the immune system. So gluten-free is kind of a fab, but if it helps, go ahead and do it. Why not? So I don't have a problem with gluten-free diet. The idea I think behind it is that gluten by being an immunogenic protein can actually bring on all kinds of different reactions, whatever they are. I cannot be more specific. So if somebody feels better on gluten-free diet, go for it. It's unfortunately still a little expensive and a little bit hard to follow. But hey, I mean, we do all kinds of things to feel better, to look better, to whatever. So yes, go ahead and do it. Fibers, I want to go back to that. Dr. Reynolds talked about fibers. I usually tell my patients, I think somebody asked about, maybe it was you, somebody asked about that, I was told not to use fibers. Too much of fibers can actually make, create a backup in the system. So you got to be careful with how much of that you're using. We talked about the probiotics. I use probiotics in patients. I recommend using it who actually use that antibiotic therapy for small intestinal bacterial overgrowth, because what happens is you wipe out the bacteria and then you have to repopulate. So the belief is that by giving the right combination of bacteria back into the GI system, you're giving yourself a chance to kind of repopulate and have those bacteria grow abundant and have good stuff in your stomach. Sometimes taking too much probiotics actually can be harmful because you're adding to the overgrowth, if you wish. So all of it is a very delicate balance as I'm seeing it in scleroderma patients, and we just kind of have to figure it out as we go along. So I do promote, you guys know that, I say that I think juicing is a good idea when you want to eliminate the heavy fibers, but you want to get the nutrients out of the diet because it's easier to digest and easier to absorb the vitamins and whatever other nutrients from that kind of diet. But again, I don't think there is one fits all kind of situation. It's just got to be on the individual basis. And I do spend time on discussing that. And you guys have been instrumental in giving me information about what worked, what didn't work. So that's I don't know how scientific that was, but that's pretty much how I look at that. Yeah, you want to say something?
She got my one of my triggers with the juicing. I usually tell people not to juice, but I think in probably a very select number of people. So if what worries me about juicing is kidney dysfunction plus fluid shifts because juice has a lot of oxalate in it. And when individuals get dehydrated, usually, with these GI issues, you're already feeling pretty lousy. It's easy to be dehydrated. In those kind of situations, you can precipitate crystals in the kidneys, and it can lead to a rapid form of kidney injury. So that's my only concern. It's still incredibly rare. It just happens to be something that's kind of on my radar because we saw a series of patients at Johns Hopkins with that. So statistically, it's probably still the right thing to do, but just be cautious about that, I suppose. The other thing, I guess I should say something about FODMAPs too. The FODMAP diet, the low fermenting food, seems to be good for people that have a lot of bloating. Helps reduce a little bit of that mechanical disadvantage with the distension, and people seem to give good feedback about that.
And it says no apple. So
It's hard to do. Yeah.
And he just said apple, and I was like, okay. So yeah, it says no apple because the apple evidently causes bloat. So yeah, and again, it just comes down to the same point that it has to be very well, designed for the individual patient. So I wasn't aware of the oxalate stuff. So I guess in Philly we do it better than at Johns Hopkins. A little plug. Plugged it in. Yes, go ahead.
Oh, since scleroderma. Since scleroderma is a relatively rare disease, the last seminar showed a overhead, I think it said less than 500,000 people. Is that now growing? Are there more people each year getting this disease?
I don't think that the more people, I don't think there are more people who have the disease. I think we just know more about it, and more people get diagnosed because of the knowledge, of the awareness. You guys, any increased rate? I don't think there is an increased rate of the disease.
They have done is increase knowledge,
Right.
increase
Awareness of
awareness from patients as well as primary care doctors. We're seeing more people being diagnosed.
And along that line, we're working with people like Dr. Smith to put on a CME that increases the knowledge of the physicians that are out there and the Poconos and places like that where they have never seen anything like it. So we're getting better at making sure that the physicians are also educated in the disease and the manifestations of it, so that they don't get patients coming down here in their cars because they've been misdiagnosed for like 5 years.
Yeah, so I think I still see some not diagnosed cases, or some cases who have been just like, I don't know where they have been, by the time they get to us, they have advanced disease. But I do see a bunch of people who are being sent to rule out scleroderma and they don't have it. So that's perfectly fine. We'd rather say you don't have it, everything is good, you got the primary Raynaud's or whatever that may be, no scleroderma. So I think it's shifted towards the rule out scleroderma, but the person really doesn't have scleroderma. That's it? No? Okay.
Any other questions?
Back to the diet. Have you ever looked into polyphenols and how they affect your gut and digestion?
They were like this. They say,
No?
she's
Okay.
up there, she'll answer. I did too, but I can't recall what I read, to be very honest with you. I think I read something about it, it didn't catch my interest.
So it's fairly new then.
Probably wasn't interesting enough for me to kind of dig into, but I've got to go home and look at it. If I can think of anything, I'll put it on the site. Yes.
I just wanted to get an update on the studies that are currently
Yeah.
in flow. treating. And I'm interested in that because, as I mentioned in previous sessions, my family has a huge history of rare cancers and autoimmune diseases. And
Okay.
it's just growing in our
Yeah.
family, in the women
Okay.
only.
Okay.
So I'm interested in where we are.
So we don't have such a study. That would be like an observational study, we call it, or sometimes, there are some scientists who take blood to kind of look at the genetics of that. We have, okay, go ahead.
Anybody has scleroderma in the family?
Yes.
All right, so we have a study called the GRASP study, which is African American patients with scleroderma. We take the blood and we send it to the NIH. We have, Jackie, remind me, 21 patients in the study right now? Right, so we have 21 patients in the study. It's a national study. It is all over the country. I'm not sure if we're 2,000, 1,000, I don't know. Right, all African American patients. So if you want to give blood, Jackie's here. So we're looking. So we're trying to better understand the disease in African American patients. We have data on the genetics in Caucasians, but we want to do that. It's at the NIH. That's the center. We're one of the centers here. Like I said, we have 21 patients. We'll be glad to make time for you guys. Probably not here, but another day. You have to sign consent. There's really nothing treatment-wise. We just send it, they analyze the genetics. Hopefully, next generations will understand the disease in African Americans. Maybe there's a way that we do it differently in African Americans. So we really, I tell my patients, there's really nothing that you're going to gain. Hopefully, maybe the generation after. So, if you are interested,
Yeah.
we'll be glad to see you guys.
Go ahead.
I actually just wanted to find out if there was any kind of connection between scleroderma and pregnancy. I wasn't actually diagnosed until after I had my son and was wondering if there's any possibility that if getting pregnant again could make my symptoms worse.
Okay. I'm not aware of any studies that show that pregnancy brings on.
Okay, she knows that there's a study, but she forgot about it.
Oh, that was so nice, right? Oh, the microchimerism, right. All right, you know what? I give it to you. I give it to you. I'm not doing it.
So there was a researcher at Jefferson who now is at Drexel, and she published in the New England Journal of Medicine years ago.
Don't lick it because Ligon had it. He had it. Okay, so I'm just like that.
Right. So years ago, there was a nice study that was done by Carl Arlett, who was at Jefferson, then moved to Drexel. She's a basic scientist. That showed the microchimerism. And actually, it's typically seen in women who have had a male child. And that was the theory that...
No, she just proved it through that because she was able to pick up the Y chromosome from the female. She couldn't.
So they found, so if they could, exactly. So what they saw, she saw that in the skin of the female patient who gave birth to the male child, there was Y chromosome, which means that somehow there was a potential graft versus host reaction with the fetus. There was transmigration of these cells into your body, and this was sort of a reaction to that. It's rare. It was a big theory. It was a huge theory, but it did not explain scleroderma in men. It did not explain scleroderma in women who never had a male child. But it was a theory. We still talk about it. It has not been redone. The study was not redone, but it was actually good enough to make it into the New England Journal of Medicine. And actually, she did a whole career studying this. Again, it's interesting. Maybe in certain groups of people, this might be the pathophysiology that brought it on, but not in everybody.
Right. So then there were like possibilities of the man maybe got the cells from the mother, and then there was an idea that maybe the women who have never had, I don't know, I can't remember what the theory was for that one, that women who never had a male offspring, they still found Y chromosomes, but it was much rarer or much more rare than it was. So it really didn't bring a very clear-cut result. But I think I'm still right in the sense that I don't think there is a trigger. So if somebody, you know, we have, as a curiosity, if they say, well, I was pregnant, I got the baby, and then soon after that I developed scleroderma, we won't file it into, yes, it was triggered by pregnancy. It's more of like a curiosity, possible environmental factor. So I don't think there is, so sometimes, like in lupus, we do see new diagnosis during pregnancy. That's actually common, but not in scleroderma. And I do not discourage my patients when they want to get pregnant unless they have end organ damage like lung or heart or sometimes kidney. We do not see, you guys correct me, we don't see any signals that would say that if somebody has scleroderma, pregnancy would make the disease worse or whatever that may be, or make the disease better or whatever, you know, what we see with some other autoimmune conditions. Okay? I came out of it. So?
Do you know if there's any connection or surveys being done between hereditary angioedema and scleroderma?
Wow, let's Google it. Hereditary angioedema. I'm not aware of that. I think it's if we see something like that, it's usually just coincidental. Not aware. You? Okay. All right. Johns Hopkins is coming.
No, I'll give you my hand-wavy non-immunologist version of that. So we're learning more and more about early systems and early problems in complement driving autoimmune disease. We know that families that have deficits in the early components of the complement system. The complement is part of the body's innate immune defense that's supposed to help it fight off any kind of infection, attackers that it hasn't seen yet, so that you can still fight off things that you haven't had a chance to build antibodies to. If there's defects in that pathway, there's a whole bunch of proteins that are all supposed to flow from each other and then end up in a very carefully organized immune attack at the point of whatever is triggering the complement system. So there's a lot of places that the complement system can get confused and cause problems. In hereditary angioedema, in the C1q part of that complement system, you can have inhibitors that can set that off. You can have inherited forms of that individual complement molecule. In those high pathway, because everything kind of flows down from that, when the complement system is chronically being activated by problems in that part of the system, it seems to give people more of an opportunity to develop autoimmune disease. So I'm less familiar with hereditary angioedema. That's I think the hand-wavy part of this. Oftentimes in individuals with C2, C3, or C4 hereditary problems, we do see higher incidences of lupus, scleroderma, a condition called antiphospholipid antibody syndrome. These things all travel together, and there's active investigation as to whether scleroderma renal crisis is in that family of a complementopathy, an acquired complement problem that's driving this. And there's some people that are starting to do a special type of assay in individuals with a history of scleroderma renal crisis. I don't think that's being kind of formally done in a multi-institutional basis yet, but I think it's on the horizon.
Yeah, it's okay. We'll wing it.
I was wondering if anything's been done with platelet-rich plasma. You know, they talk about injections around the body for use of that for blood stimulation or other things. I was just wondering if they've been looking at that for fingertips and things.
So platelet-rich plasma has been used for joint osteoarthritis and inflammatory form of osteoarthritis in some institutions. To be very honest with you, I don't even think that actually pinned out to be a good therapy. They are using some for sports injuries, like hamstring injuries, Achilles injuries. They use platelet-rich plasma, and the idea is that they kind of stimulate, like it's almost like they're creating an inflammatory situation, and through that whole cascades of events, they are seeing improvement in tendon inflammation. But I have not heard. Have you heard plasma? Yeah, me too. Because it's a pro-inflammatory. It's a pro-inflammatory therapy rather than, and again, so it's on that line of boosting the immune system kind of situation, where I would also be, just theory-wise, I would be cautious. But again, it's just a theory, just based on what we think, not scientifically proven by any means. All right, thank you very much.
Big acknowledgement to Dr. Sandorfi. Do not forget to turn in your evaluations, as well as take with you all the events we've got going on, because we'd love to see you again, and not just this once a year. Thank you all for being here. Truly appreciate you.